Just takes a moment to kick in. So the recording should be showing up eventually within the chat of this, which is maybe useful for those of you that want to play anything back. So first of all, I need to apologise to any of you who signed up for this back in July or late June, when we organised ahead of time that we would be doing a talk on the 10-year plan, because the government told us it would be out in spring. So we assumed that by getting something in the books that early summer, we would be okay. Unfortunately, the plan didn't come out until the first week of July, and obviously that meant that things were running a little later than we expected. I know that GP Excellence sent out apologies to everyone and emails to suggest that everything would be cancelled, but I know that some of that didn't get out to you, because I know there were a few people that actually joined the course. Would have been marvellous if I could have taught it before Wes Streeting had released it, but unfortunately I don't have that kind of insider knowledge. So to give you a little bit about me, if those of you that haven't been on my courses, I know many of you have, because I can recognise the same initials coming up, or those of you that have pictures on your profiles, I can see the same people that I've seen many times, but there are obviously going to be people that haven't listened to me before. So to let you know who I am, I have been a practice manager for several years over lots and lots of areas. For those of you who have been on very recent courses of mine, you'll know that I have recently taken early semi-retirement, but I am locum practice managing to keep my hand in to make sure that my information is up to date. It just gives me a little bit more free time. I also train and mentor for obviously for Manchester GP Excellence, also for the Lancashire Training Hub, and for the LMC in Preston, Lancashire and Cumbria. And I privately consult on estates. Part of the reason with all the extra stuff that I'm doing, that I decided to start to locum, so it gave me that free time and freedom to carry on seeing all of you. So as far as housekeeping, be aware, for those of you that have joined a little bit later, that we have put this on to record. So we are recording this session. So do try and think of this as face-to-face, but do keep yourself on mute unless you're asking a question, just purely for the fact that any background noise is going to come out on the recording, and maybe things that you don't particularly want to be recorded forevermore coming out. Please share your thoughts, interact, ask questions if you want to, and I will do my best to answer them. And if the slides stick, let me know. If you're having any issues, let me know. You can pop something in the chat if you don't want to take yourself off mute. And also be aware that I work on my own. I don't have admins switching over my slides, reading things out to me from the chat or anywhere else. So it may take me a few moments to get back to things if I am in the middle of a sentence, because there's not always somebody there to assist and push me forward onto those particular areas and let me know where we are with things. Everything about the plan is something that I know all of you could do. I don't have any special government powers. It is just an awfully big plan to run through the 156 pages of plan that I have worked through, just to try to put some semblance together so that you're all aware of what I have seen in that plan, and whether that may help you to have a little bit of understanding without having to slog through everything. I've also done a action plan type area, not as many actions for you to have to do, but some shortcuts about the plan, which will really summarize it very quickly for you. And that will come out to you after this session. And when that comes out, it will be guide by guide, section by section of the plan, because the plan is all sectioned up. And it may be helpful if you're trying to explain things to your partners that are going to happen going forward, just to have that bit of a shortcut. That's what it's there for, and hopefully you'll be able to use it. I believe also the slides will come out to you They don't come directly from me. Everything comes through the GP Excellence site, so they will be sorting that out for you and sending those things out for you. Those of you that haven't even got as far as having a look at the plan, there is the link that's attached in here that will show you exactly where you can find the plan. It's on the NHS England website, as long as we have NHS England, and you will be able to click through and have a look at the plan yourself. Although all sorts of things that even since I set up these slides, things have started to change, and things that have been added into here because this is what we were told was happening are being slightly altered already. So a 10-year plan of what's going to be happening in 10 years and even the stuff that was supposed to be happening right now seems to have slightly changed. So we started with the road to recovery stuff that came out, and Wes Streeting held a mandate to improve the NHS, and his big areas he wanted to look at was cutting waiting times, improving access to primary care, and improving urgent and emergency care for everyone. So they were hoping that with waiting times, they would reduce patient waiting times and give patients more choice where to be seen, and make mental health a priority. And mental health is mentioned a few times when we get to the 10-year plan, which was came after the initial road to recovery. And then they want to do some improving of primary care access. I'm sure, and this is my opinion and not that of GP Excellence, but I'm sure many of you have heard this many, many times. If you've been in general practice for a long time, as I have, we have heard various statements coming out as we get new plans. We had a 5-year plan. We had the Darcy reports many years ago, lots of things that have happened, and the new Darcy reports that have come out. So as more and more things happen, we have heard this talk of improving primary care access and lots of different ways to stop the 8 a.m. rush on the phones. This way, we're looking at more AI. We are looking at other ways of improving things, and you'll see as we go through the plan all of the ideas behind various parts of that. Lots of investment talked about in data and digital awareness, lots of digital stuff coming in, which is supposed to help and hopefully will if it's used correctly. And then there is ensuring there is a focus on dental care. And why am I mentioning this today? Well, I'm sure many of you get those regular phone calls to your practice where I can't get in to see an NHS dentist, I have pain, I need to see a GP. And at times they will work their way into an appointment that really should be a dental appointment, but unfortunately because they have nowhere else to go, and that sits in front of the GP. So changing and improving dental care should hopefully actually stop some of the appointments getting through to you. There's also a lot of work on pushing together and working with pharmacy. So we will talk about that as we go through. And lots of things about improving financial flows within the service, so how that money is going to flow a little differently going forward and not plugging the gap in the hospitals. It sounds great at first that everything is going to go to primary care, but obviously that is going to come with its own difficulties, as many of you will have difficulties with estates. Lots more working together in much bigger footprints than PCN. So it is a case of learning how to work very, very differently going forward. There is also talks about improving urgent and emergency care to support that reduction in waiting times. So they are looking at if we can improve the urgent and emergency care, we can maybe stop some of the things flowing forward. Improve patient flow through the mental health crisis and acute pathways by putting in new infrastructure for mental health, making progress towards reducing hospital admissions, taking first steps to building those neighbourhood health services that we are all going to expect to eventually be part of some big building that contains all of us. Both GP and urgent care and all sorts of other things, and we'll talk about that as we work through the plan. And also in financial incentives to support urgent and emergency care performance and improve the use of resources by tackling unwarranted variation in performances. So they are talking about standardizing things so everyone doesn't do their own stuff, but we actually get a bit more standardization across things. So the 10-year plan has 3 headline acts, that is hospital to community, sickness to prevention, and analog to digital. So these are the things that they are announcing that will happen. You'll see this a lot. This is the Fit for the Future 10-year plan logo that's coming out, and the 10-year plan has 9 separate sections, and we are going to run through each section today. Section 1 is purely an introduction to the plan. If you read it, you can skim through section 1 really because it's repeated in each of the other sections. They have commented that 25% of patients in our country have a long-term condition, and it talks about areas, what's gone wrong and why we need to make changes. It talks about us having a growing population, plans for investment, and a big focus towards digital planning and neighbourhood working. And many of you will have seen that there are bids already going on for 42 different large groups of practices working together across a big footprint to take on some of the things that are traditionally in hospitals, and we will talk about that as we go through as well. And section 1 does really make it clear that general practice will still remain. It's not going to be sucked up completely into this, although there are definite suggestions. And again, this is my opinion, but the way it is written, it does suggest that the partnership model is being pushed backwards, and eventually most GPs will be salaried eventually. They have stated they are not stopping the partnership model, but it certainly doesn't appear, if you read the whole plan, that it is being particularly encouraged in going forward. They have said that ICBs will remain and actually take on quite a big role, but while they're taking on that big role, they are making 40% cuts to most ICBs, and I know that personally from the Lancashire area where I've been based, that the redundancy notices or letters for putting yourself forward for voluntary redundancy went out last week to the ICBs. So I imagine something very similar will be happening in Manchester. PCNs will continue. That has been made very clear. And if anything, they will grow, and working at bigger levels is going to become more the norm. The Darzi report. So we had the original Darzi report. For those of you that are nearer my age than some of the younger practice managers out there may remember, the Darzi report was originally happened when Tony Blair was the Prime Minister. And obviously, for those of you that are too young to know who Tony Blair is, as a past Prime Minister, he did a big report by Lord Darzi, and that report has now been re-completed under Sir Keir Starmer, and looking at the same kind of thing, which is these big health centres coming in that also have acute services and dentistry all trying to work together out of one building. It's a plan of change, and any of you that went on that Amanda Doyle first webinar about the plan made it very, very clear that this is a plan that can help work for everyone as long as you are prepared to change. If you work in a practice that has very sort of old-fashioned or traditional ideas, and maybe doctors that really don't embrace the change of AI coming in, or moving towards more data things that aren't there at the moment, there is a risk. If you are resistant to change, the money is not going to flow the same. So we all have to learn new things to work forward, and that's been made exceptionally clear within this plan. So we are going to look at section 2, which is from hospital to community. Now, if you actually pick up the plan, if you haven't looked at it yet, each of the plans will have a little blue picture like this and some sort of sections that show you the way that they feel that each of this section is going to work. So we have bringing the NHS to your community, modernising hospitals, a new era for general practice to stop the 8 a.m. scramble, bringing back the family doctor, creating different types of teams, and these neighbourhood health centres that are going to be built in every community with multidisciplinary teams working together under one roof. So this is the general plan. They are going to have these big neighbourhood health centres in every area. What that means for small practices, they haven't made clear at this point. We're not sure who's going to move into those health centres. It's very much a 10-year plan and not a today plan. There is a lot of focus on the NHS app, and there is a section where we are really going to run through the NHS app and all the different things that it's going to be able to do going forward. There is going to be a lot of connection going through with hospitals as well, working through the app. So it should reduce some of those calls into general practice, and we will talk about that as we get to the part about the app. There is going to be an advice section where people can call and ask for advice, and they will be given advice, sort of AI type advice. There will be a lot more self-referring as we go forward. And they have brought back an old phrase. I believe this was a phrase that was used back under the Conservative Party with, I can't remember. It was one of the big private things that came through with private healthcare, where they describe that as a doctor in your pocket, and this phrase is being used rather regularly. I don't know what your doctors are going to think to hear that the NHS app is basically a doctor in your pocket, but that is the phrase that is being really coined a lot. One big area that is being looked at is this genomic data to predict care that will be required. It's actually quite interesting that probably 3 months before the NHS 10-year plan came out, my pharmacist was working through doing some actual research on genomic data to work with patients and seeing what things were going on within their bodies to work out a plan for them before things went wrong to actually stop stuff from going forward. He had a real interest in this, and then all of a sudden there it is all over the 10-year plan. So we were fortunate enough to have got in early. There is some links that I have added on that you may want to pass to your clinicians to have a look at potential research that is involved. It is paid research, so it might be something that you could sort of jump on to get ahead of the game as this is all coming into the 10-year plan, and also make some extra money coming into surgery. Research has become very, very big within this 10-year plan, so it all sort of knits together. So I've pulled the different guidelines that were around surrounding the research, and you can take a look at those links in your own time and have a look and see exactly what this genomic data is looking at. But it is looking at a lot of prevention going forward. It's looking at how different drugs can work and react within bodies due to their makeup within the body. It is actually quite fascinating, particularly for some of the clinicians who are really forward thinking, but it is definitely a forward thinking way to work within the plan. So as we're talking about going from hospital to community, they are talking very seriously about these neighbourhood health centres. Everyone's going to feel differently about how these are going to work. They are talking about one big health centre in each community by 2035. They are going to start with the more deprived areas. They are going to build these big buildings. Often repurposing current buildings or repurposing old hospital buildings that have been disused, not used anymore, or land that hospital owns, so that it's not as costly as one would imagine. And the idea behind it is that you have this big building that someone can go in and see their dentist, see their doctor. There will be a Start for Life in all of them, which is a hub for children and families. They believe that this will then help people feel that that is the proper neighbourhood health centre. These were Darcy centres back 25 years ago, I think, when they came out, when the Darcy plan first came out, and this is sort of been reinvented and added to. So this is your neighbourhood health centre. I know if I was younger, back in the early days of my career, this would have looked really exciting to me, and this is exactly what I would have wanted to be overall managing, something really big. It's not going to be like that for everyone. Not everyone's going to feel super excited about it, but it is something we are going to have to learn that is coming our way. Whether that is going to be these health centres are going to be as well as lots of general GP practices hasn't been made clear. Certainly, it doesn't mean all the GP practices are going to disappear and there will only be one health centre, but I am sure it's going to be a case of bidding for who goes in there on looking at exactly what area it is going to be situated in and how that's going to sit with your patients. They've also talked about freeing up GP capacity by stopping bureaucracy, removing targets and improving on red tape. It's again something we've heard before. We will have to see. I know certainly with the QOF targets that were removed this year, actually they weren't stuff that really was too hard to do, like maintaining lists. Those have gone, and they were areas where you could easily improve money with things like prevalence, which some of that has now been removed. So I'm not sure about this stopping bureaucracy, but we will have to see. And hopefully there are certain areas of this plan that really look like they are going to stop certain amounts of pointless work, which would be really great. By 2027, there'll be technology to use AI scribes, from voice technology for clinical note-taking, letter drafting, data entry, digital phones for all surgery. There is that stuff out there now. It's not going to be a case of we don't want to use it. It's going to be a case of this is what you will be using. So you are going to have to get used to that. Some of you I know are really forward thinking and you are already using AI to do your minutes for things, which is great. You'll have some doctors that are using it to do their clinical notes, but it's going to be pushed out and everyone's going to be expected to embrace this going forward. The part about the dentistry contract, so basically every dentist that qualifies, at the moment there is no rule. They can be go through and do all their qualification work and then immediately become private, which is why there are not really many NHS dentists out there. Now all dentists as they pass will have to do a 3-year NHS contract before they are allowed to take on private work, which means we should have, as new dentists come through, there will be more NHS dentists, even if it is only for 3 years. But there are constantly dentists each year, obviously, who are passing their dentistry, and if each of them has to do 3 years and an NHS contract, that should improve dentistry going forward, which should help us all, as I mentioned earlier, with calling up with dentistry issues. They are saying that we will have 2-year contracts for our PCN contracts to make things easier. At the moment, you are taking on our staff with that fear of not knowing what is happening year in, year out. So apparently it will be rolled into a 2-year contract. And then there will be a second contract, which is the one we mentioned earlier, for areas with 250,000 patients. So you will be looking at working at scale. Working at scale will also be bidding for things that are currently done by the hospitals. So if you have got a really good organised area, they are having 42 new contracts to start with that people can bid for. There have been some webinars from NHS England concerning those contracts, so where you can put yourself forward for that, but you've already got to have a agreement across your your area for those 250,000 patients. So that could be several PCNs together. It's looking like places like where you've got federations and alliances set up. They are probably going to be the ones in position to bid for these at the moment, while other people get themselves organised. They are also, you've got to have a relationship with local council, with local other NHS suppliers. So those relationships, they're going to start with people that have already built those relationships to make it easier. And then as time flows on, you can start building those relationships to get yourself in a position to bid for these big contracts. But as I said, I think it will start with federations, alliances, those kind of things that are already covering those large patient cohorts. They're looking at having shared back office functions, estate strategies, clinical trials across large areas, and they will also take over assisting practices who are struggling financially or with their performance, so they will get sort of sucked into these bigger areas of work. And teams within these areas will have mixed professionals alongside adult social care. So there is that first connection that we are trying to get together, health and social care working as one. There will be a big increase in care plans. I'm sure many of you have got all kinds of things where you're doing care plans for your housebound, care plans for your people in care homes. You're already doing a lot of that under the PCN DARES or under various local enhanced services. There's going to become a lot more of that. And we are going to be encouraged to invite our unpaid carers, whether that's family members, etc., into conferences where we are discussing with them the care of their of the person they are caring for. Every care home patient and every patient with multiple long-term conditions, all frail patients and all palliative patients will be expected to have care plans. And this is going to be added into your contracts as we go along. And by 2029, there'll be the implementation of the National Neighbourhood Health Implementation Programme, which will work alongside all of this. So we've got a bit of time, 2029. To get things into place. And most of these plans you'll see, I have put a timeline on when you get this action plan that comes out, so you can have a quick, easy look and see exactly how that looks. But there are lots and lots of things coming up that we need to be aware of. So, excuse me, I'm getting a dry throat. So, section 3 is from analog to digital. This is a real big area, actually, particularly more for hospital than us, because we are somewhat there, although there's plenty more we can do to become more digital. The hospitals are way behind, and I'm sure if any of you have been unfortunate to have a hospital appointment, I have myself recently, and you would still see the porters walking along with a trolley with a great big pile of notes that they would put in front of the consultant because nothing is digital. We've obviously all been working off sort of EMIS System 1 forever, and really those paper notes have been scanned in most surgeries. If not, they're happening as we go. They're starting afresh in the hospitals, but they need to get ready because we are going to have this single patient record from the moment we are born until the moment we die. And that record is going to include your hospital care, your GP care, your opticians, all of those things. It's going to be there, and it should be available for most patients by using the NHS app. Obviously, there are those patients that, as you know, we don't allow to have that access for their own mental health reasons. But in general, that single patient record should be available. We are looking at that's going to be sort of a 10-year plan. They are encouraging people to embrace AI going forward because it is going to be used a lot more. Then they are calling the NHS app not just the doctor in your pocket, but also a virtual assistant. So there's some quite fun words coming out there. And then we are going to discuss and look forward to see how patients are going to be able to manage all of their appointments and discuss all their care through that app, which should hopefully start to assist your staff and free up their time. So that single patient record, as we talked about, will be coming up. They haven't made clear how it's going to happen. And it sort of sent a bit of a shiver of fear to me personally that patients will not only be able to see the single patient record, they'll be able to add to it themselves. They haven't said how. I'm not quite sure that I want patients, unless they just mean uploading blood pressures and things like that. And hopefully that's what they mean, not adding their own opinions about their health, but we'll see. And by 2028, that single patient record will be fully available on the NHS app. So that means all the hospitals have 3 years to get themselves sorted. There is lots of different areas going on the app. So there will be My Care area, which will be a patient's care plan, My Companion, which is a part for those who need support and help them see all different information on different conditions. There will be translation available on that and support where they can ask questions. There'll be My Medicines. So that at the moment is your prescription area. Everything, if you notice, is going to have My in front of it. So there will be the My Medicines, helping people manage their prescriptions. There will also be a guide for patients on drug interactions. So that will hopefully stop a few questions. My Vaccines, so everyone can see their vaccines and what's up to date. And for babies being born in this time, hopefully that means a full record, because if any of you are a little older, like myself, you will know that because your vaccines were done by a midwife at that point, they weren't added to your main record. They may have got lost over time. And if your mum didn't have the initial thing that was filled out 50, 60 years ago, then you don't know that you had all your baby vaccines. None of that should be happening going forward, because everything should be on that one record. And then there will be your bit called My Health, which will have your BP readings and your blood test results, etc. Then there'll be the My Children area, and that will contain hints and tips for what to do with when you have your first baby, understanding about their sleeping, feeding, all of that sort of thing, so people can look up their NHS app and get this information. There'll be a My Carer part where people can actually give the app to their carers, and responsibility that their carers can get into their personal thing and they can actually agree to that. AI will transfer information into actions for clinicians and staff. We know further detail on that. I'm assuming that will go out as some form of task, but it does say that this should stop the human part of the job where people are currently coding, looking for actions, tasking doctors. That should be happening for us with hospital letters going forward. Sounds wonderful in theory, just depends how well it works, and that's something we'll have to see. They are going to work with libraries for people who do not have digital equipment. So the I don't have my phone isn't going to, or a phone isn't going to work. You will be expected to go to a library, and there will be sign-ons you can get onto your app from there. And then there will also be people teaching at the libraries on how to use digital stuff and use an app. And they've said there will be a single sign-on for staff for absolutely everything that we use. So not just for this app, but everything we use will be under one sign-on. So you don't have to remember all those passwords. That sounded quite good to me. Maybe the younger ones of you don't have so much trouble remembering all this stuff. It'll come to you one day. So then we have section 4, from sickness to prevention. And this is where we are looking at things we can do to assist people to look after themselves. So we are looking at tackling childhood obesity through new junk food advertising restrictions, looking at improving food in schools, encouraging people to have all the information they need on healthier choices on alcohol, looking at the zero alcohol products that are available and working through those with people, looking at air pollution. So if you've got a greener strategy within your practice, you are part of the way there, because we are going to have to start looking to make things greener. Working with businesses to help children and families make healthy choices. People will be encouraged to move more and exercise more with new national campaigns, and they are hoping to create the first smoke-free generation, because they are cracking down on smoking and vaping for young people, and hopefully this should stop a lot of that going forward. So when they talked about from sickness to prevention, they did mention, and I know it's not your area, but it's close by, that Blackpool has the lowest life expectancy in the whole of the UK. Having worked there, a lot of the preventative stuff could have assisted with that, and a lot of education could have helped. I know it was horrific when I was working out of there. But all areas, particularly the deprived areas, they need to work a lot more on prevention. So there is going to be no more sponsoring for vapes, so less money going out there. And just to make you all laugh, I was quite horrified in seeing an advert in a local paper here where there was a doctor of a GP of a single-handed partnership who was actually had his picture up in the local vape shop saying, "Try vaping, not smoking." Obviously, there's so many dangers around vaping, that really wasn't great. A lot of that will be stopped. There's a lot of launching health coaches this year, so there is going to be particularly around smoking, some health coaches who are going to advise people how to give up vapes as well as giving up smoking. And people are going to be pushed into a position where they have to give up smoking ahead of a procedure. And if they are still smoking, some of these procedures will be put on hold, so they will not be able to have their operations. They are going to look back at genomics, as we mentioned earlier, and work with those to prevent diseases happening in the first place, because they will be able to know what's going to happen to people. So this genomics coming up again. It's going to be a lot of work. Obesity is the big issue at the moment. So as well as all these weight loss drugs, which I know is going to be the bane of your receptionist lives at the moment with all the extra calls coming in about them, there are going to actually be restrictions on junk food advertising. The schools providing those nutritious meals, the Healthy Start scheme is going to be reintroduced in 26-27. Expanding free school meals to make sure children are actually eating a school meal. There's going to be, from October this year, a ban on buy one, get one free on unhealthy food. So any of you that, maybe pick up bits to go in your kids' lunch boxes, if they are chocolate, or buy one, get one free on biscuits and things, all of that is going to stop encouraging people buying junk food. There will be more digital weight loss services. As you know, there are, you've got that enhanced service where you can get people and refer them onto those digital health weight loss services and claim for each referral. So there will be more of those weight loss services that you can encourage people to get involved with. And there are some consultations happening on alcohol labelling. Active travel is going to increase. I don't know if any of you have looked at this, but there are active travel grants in all areas, and you can get certain grants that are making improvements to your surgeries. So I know I got a grant to put up a bike shed and have that available. So if my staff or patients wanted to cycle, they had somewhere safe to lock their bike and keep it dry. There are grants out there for that kind of thing to improve the greenness of your surgery. By 26-27, there will be a big piece of work from the government on increasing walking and cycling paths, which will be great. So you can walk more, cycle more, and hopefully that will encourage people to get outside. They are going to put in some work on improving rented home standards. So we've all seen all the awful news things with mold in people's houses that are giving them respiratory issues. Well, there's going to be a lot of work around this. So this is the wraparound preventative work that are hopefully going to improve people's lives and stop them coming to the doctors with those problems. There is going to be a Get Britain Working white paper. So that is to address issues where people are not going to work. So to try and stop some of the sick note culture that's going on in the country, which hopefully will free up some GP time if they have less sick beds to deal with, but we will see. They are looking at working on increasing vaccines in children and getting more mental health support for young people, including mental health support going into all of the schools. So that is the end of section 4. Still got 5 sections to go. I haven't seen any questions going in, so I am assuming that you are all okay out there. If anyone does want to ask anything, you want to type it in the chat, I'm quite happy to pick it up as and when I can, but we will ask you all at the end as well. But just in case you're going to forget something as you go along, because there is an awful lot of information within this 10-year plan that we're all working through. Section 5 is called A Devolved and Diverse NHS, which is looking at tackling health inequalities, building those new neighbourhood health services, and looking at the national leadership, setting strategies, priorities and standards. As you'll see, there are certain things that keep appearing in each section. The health, those new neighbourhood health services keep showing up. So does the genomic work. It will show up in 2 or 3 different places, which is why I've done you this action plan to try and help you work through that and just see if you're trying to do a shortcut for your partners as you're explaining this to them. It's a little bit easier than getting out the whole plan and thumbing through it, because it does repeat itself quite a lot. So the things that are going to be happening, they are changing the regions. So they are going to put things more at scale. So for those of you that have been around for a long time, you will remember there have been lots of changes between PCTs. Then we had CCGs that became very localised. Then they decided to go to ICBs. So all the localised stuff then got pushed out to become across your area. Now they are going to regions. So there will be 7 regions. They haven't said exactly what that will be or where they will be. There will still be ICBs for every area, but they are going to be reduced to 42 across the country. But when we look at these regions, certain parts that the ICBs now cover will go to region areas. Now, the one I know is definitely going to regions, because I've had conversations with local members of the ICB that it's happening to, is estates. So for instance, at the moment you will have an estates lead in your area that's connected with your ICB, and if you are making improvements to your building, adding an extension, looking at a new build, you would have your localised estates lead. That is going to change. So there will be 7 across the country instead of 1 for each ICB, and they will run large areas, so they won't necessarily have the local information, the localized knowledge about an area when you are going forward to somebody that's maybe 100 miles from your place of your surgery to ask them about something connected with estates. They may not know the intricacies of the village you work at, or the really deprived area that you're in the middle of. So this is going to change things. I know it's going with the states, but it is going to happen at lots of other parts of the ICB as well. It is simply that I've had a discussion with the estates lead around here, and they have all been told that they will have to move area to work out of one of these NHS regions or terminate their role. So there are lots of things that are changing. Each area, so I'm assuming these big regions will have action plans drawn out for failing providers. Providers are hospitals, they are also GP surgeries. So it's become even more important to make sure that you are doing well with things like CQC, because they are looking at failing providers. And those failing providers can then have their contracts changed to make sure that they can then provide. They haven't given us great detail on how that will happen. The NHS Foundation Trust will be brought back, and all NHS providers, including GPs, will be classed as part of an NHS Foundation Trust. And then new integrated health authorities, known as IHOs, will be created. They have been doing some pilot work in this actually in the Blackwall region, where they were looking at working at force or at strength across all of the PCNs across an area, having to work in the same manner and working together. It's in very early stages, but then it's appeared in the 10-year plans. There was obviously an idea behind that. And then there will be a health and wellbeing board that will be formed to have partnerships with local governments. So you'll be looking at working at bringing everyone working together to improve health and social care. That will include working with local mayors. Obviously, places like Manchester, you have actually got some big figures out there in the mayor world, whereas London obviously has. But when we start to get in the smaller regions, that might change the role of being a mayor for your area, because they are going to be a lot more involved with this health and well-being across an area. And then there's also this choice charter. Now, the charter was mentioned very, very briefly in our contract negotiations. And when the new contract came out in April, we were told there would be a charter that we had to put on our websites. That was all we were told. But they are actually looking at making a charter that works with sensitively with patient choice. Now, my personal opinion, I think it is quite a worry. There is something called patient power payments. So after a patient has received care, perhaps had an operation or something, the patient will be contacted and given a say if the cost of care should be fully released to that provider or not. There is a bit more explanation on it than that, but it is giving patients a bit of pushback, which can be great if you've got really patients that really understand what's happened to them and understand the bigger picture. If you haven't, that can be quite challenging, that money could be held back from providers. Patients will have control over their health through the NHS app. They'll be able to refer themselves for diagnostic services through the app, which is great. It goes through an AI triage once that's all set up. And patients who need elective treatment will have to be given a choice of where through the app. And then there is a section 6, which talks about the transparency of quality of care. So this is slightly going along with the safety strategy that came out in April, that hopefully you've all at least got yourself signed up to do various parts of. If you did come to my contract classes, I sent out an action plan. If you buried that, you might want to bring it out, because it is definitely coming back in. So a new transparency of quality of care. So when patients and their carers have safety concerns, they will expect a personalised and rapid response, where managers and clinicians will listen carefully, engage compassionately, and provide answers to questions. CQC have a change of time limit where they can bring legal action against a provider. So It has been 3 years at the moment, and that is going to be brought to happen a little bit quicker, so that we can make sure that people can sue or get information back out of people much quicker via CQC. Integration of freedom to speak up guardians into workplaces, because staff must be listened to. It's unacceptable that poor quality of care is allowed to persist, is what they are being told, or what we are being told. So in the next 12 months, ICBs and NHS regions will be tasked to see what needs doing across all areas, including general practice. And the bit that I'm sure you're all terrified to see is CQC are going to be given even more power using AI as well. Anyone that knows much about the maternity, which I'm afraid I don't particularly, but the new maternity outcomes signal system, known as MOS, will be in place across trusts from November, where there will be real-time data available on things like stillbirths, so that you can make sure that you are not contacting people incorrectly, because that data is going to be updated. CQC. So there will be 2 broad operating models for inspection. You will have your rapid response inspection. This is where there have been concerns identified, could be whistleblowers, could be something dramatic happened in your surgery. And inspectors, they say, will be deployed to get out and understand the nature and the significance of the problem. And then there'll be your routine planned inspections, where services are independently inspected on a 3 to 5 year cycle, depending on the level of risk. So we'll be seeing more of CQC, where that's really, we haven't really seen much of them since COVID. Section 7 is an NHS workforce fit for the future, where we talk about new standards within the workplaces and how we have to work forward with this. This is probably the most interesting section for most of you. I would think it was quite interesting for me. So there will be a new 10-year workforce plan. It's coming out by the end of 2025. I'm not going to set anything until it's out, just in case. They're going to concentrate on digital innovation, ability of using digital tools, and those who fail to innovate will fail in the NHS, are the words of Wes Streeting. Move forward or fall behind. This is something that, again, if you are in a challenging surgery, which is because it's a little more old-fashioned, you may need to have these discussions to make sure that your GP partners understand that this is the way forward, and unfortunately the money is going to be attached to it. The positives, I think, that have really come out is by 2026, in April, all mandatory training will be altered and changed, with training tasked to task instead of train to role. Now that, you may think, oh no, not more changes, but actually it's a good thing, because at the moment, quite often we get a whole list of training that seems to be nothing to do with us, that we have to follow, and that's going to be looked at. So it is a little bit more sensible. And by 2035, so for the younger members here that are still expecting to be managing in 10 years' time, every single member of NHS staff will have their own personalised career coaching and development plan to acquire new skills and practices at the top of their professional capability. So there are going to be lots more looking at training. NHS appraisal and revalidation will become real-time feedback by 2028. So things are really changing. It's not going to be, well, 2.5 years ago when you've got that 3-year revalidation. It is really right now it's going to become. Formal training by 2028 will include using AI, and people will need to start working on that. And a lot more training will be moved into community instead of hospital for clinical staff. So people are going to be coming to your practices and working through training, which, you know, now, as we know, our GP trainees are now spending more time in practice. They were embedded a lot longer in hospitals, and that's starting to move. It's going to become even more so. The bit they mentioned on nurse training, I'm afraid I wasn't aware this was an issue. Some of you may know, but apparently reimbursement for nurse student travel was an issue, getting their money back, and that's going to improve to make sure that they are reimbursed quicker. The NMC is going to consult on advanced practice standards to increase advanced roles for nurses. And you will all have seen there are this new role that's come through ours with these nurse consultants. So that's going to be worked on a little bit more, but with the NMC heavily involved in that. So consultant nurses for GP practices and consultant midwife roles are going to be rolled out. And this genomic population that we talked about previously with this genomic research, they are looking at that being nurse-led. Not sure what my pharmacist will think, because he was very much wanted to lead that, but it is certainly not going to be doctor-led. They are looking at pulling certain things out from just doctors leading everything and getting that spread across the nursing team as well, which is why we need these nurse consultant roles. There has been, this is going to take you back to COVID, when you see Professor Sir Stephen Powers and Professor Sir Chris Whitty are actually reviewing all doctor training. So those names that obviously we used to see coming across our screen in COVID, they are going to be there reviewing training. And they are looking at, there's some work to prioritise UK medical graduates for foundation training, and UK medical graduates and other doctors who worked in the NHS for significant periods to be able to put themselves forward for speciality training. So that is just to keep these doctors in our country, because we need them, rather than bringing in students to train and then go back to their own countries. They are looking at trying to do some more in-house training for UK doctors. And over the next 3 years, they are planning to create 1,000 new speciality training posts with a focus on specialities where there is the greatest need, working with the GMC to ensure a more streamlined pathway is in place for experienced doctors to obtain registration to become a consultant. I've just seen something's gone in the chat. Questions around protections for the GMS contract as part of this plan, which the government had previously committed to. They have said the GMS contract will still be renewed. That is definitely there, but these other contracts are going to sit alongside them at the moment, these bigger contracts at scale. And data implications you touched on, which GPs responsible as data controllers for a record they have less control over. Totally agree with you there. There is not much detail on how they are going to work with that. That might be something where you need to look at some of this insurance that is now going out there on your data and seeing if that can help you. But yes, there is definitely some work that is going to be needed when our GPs are being held responsible for things being put in via the hospitals, and they haven't been very clear on that in the plan to show how they are going to work on that. So I'm afraid I've tried to touch on that, but definitely the GMS contract at the moment is continuing according to the plan. Obviously, I don't have any personal contact with Wes Streeting, so I don't know if that's his real plan, but that's what it says in there. And the data controller thing, I think we're all concerned about. So we definitely need some more detail on that. As we go forward, there's talk on research. So there is going to be a lot more funding opportunities for research for nurses and advanced nurse practitioners to be leading in this. So again, we're talking about these nurses leading. And then there will be a primary care commercial research delivery centre from 2026 to specialise in commercial clinical trials based in primary care. where neighbourhood providers will have to be able to work at scale and have the data and representative population to take advantage of this opportunity. So lots and lots of research opportunities that are slowly going to be coming up. So it is worth talking through with your partners if they're not really into research, that they really need to look forward. And those practices out there that do a lot of research, because there are some that have got their whole own research hub set up, you're in a great position to improve and work forward because money is going into research. Now, this is my opinion and not the opinion of GP Excellence, but I'm going to try and control my face when I say this, because you're all managers out there. And from April 26, the new staff standards say that we need to bring joy to the workplace. Staff treatment hubs will be formed to keep people in work. That sounds great. Staff training will move across the NHS. So when you've got someone that's come in from one area to another area, their training comes with them, so you don't have to have them sit doing all this training. It will move from hospital into GP. It's just going to be one big NHS training. That sounds great, which is going to stop a lot of bureaucracy, hopefully. Flexible working to increase. I don't know how many of you were hit with all these flexible working requests when the law changed last year. I was certainly hit with loads of them. It is, you don't have to give that everyone everything that they want, but you do have to investigate, see if it's possible, and try and work ways around it. It's going to add, I believe, to managers' workload. And unfortunately, with this having to open from 8 in the morning until 6:30 at night, which is looking at moving to 8 at night, it's going to be very difficult to be flexible all the time, but unfortunately that is there. And then this lovely line that's come in, that employers must improve the staff work experience. I will leave you to all decide. We've all got health and well-being within our surgeries. We all try and make it a nice place to work, but I am not quite sure how all this can work and bringing the joy into the workplace whilst also still managing to get some of that work done. So that's there for you all. Megan has put, how is this going to be measured? If at all, they haven't said yet. Obviously, because this workforce plan is coming out later this year, I'm imagining there's going to be a lot more detail in the workforce plan, which hasn't come out yet. This is touching on it to just let us know that that is definitely out there. So it's just giving us that heads up. So the new management and leadership framework will be developed by autumn 25, which will include codes of practice, competencies, which all managers must reach. Better arrangements for senior managers' pay in hospitals and these new NHS health centres that are coming out. It says, through senior leaders who let their profession and colleagues down through dishonest behaviour, silencing whistleblowers or covering up unsafe practice, they can be disbarred from ever being a leader again. Now, when this first came out, they made it extremely clear that the parts to do with NHS managers were going to absolutely include GP managers. They have now, after I wrote all this, they have since said it will eventually include GP managers, but that is not going to be from straight away, because I don't think that they had realised the scope of regulating all managers and how much work there would be involved in that at that stage. I know that, I don't know if there's anyone on here from IGPM, but I know that IGPM are working as close as they can with the government and have put themselves forward, because they do this wonderful accreditation that you can actually be accredited. So therefore you would have that professional regulation that's sat there. But at the moment, obviously, that is something that is not standard that we have to do. It is for those people that have joined IGPM and put themselves forward for that accreditation. So hopefully, if they are going to bring this in and you are all going to have to be accredited to work within the NHS, let's hope that they work very strongly with IGPM or something very similar. So someone that actually understands the role of a practice manager as opposed to trying to just maneuver something from hospitals across. But this is something that we are going to have to be aware of. But once that accreditation comes in, there is an accountability that is attached to it for decisions. This little line here quite concerned me. And the reason it concerned me is because, and this is again my opinion, is that we all have partners. And sometimes the partners make a decision because it is their business that is maybe over your head. You don't have the choice in that decision, but you may be accountable for it if it goes wrong. That's the way I've read it. Hopefully there'll be a lot more work on that, and hopefully someone like IGPM will work with them to make sure that it is understood that when you are working under a partner, you cannot necessarily go over that partner's head on something. You can suggest to them, but you may not have the final say. So for us to be accountable would be quite a concern. But we will see how this pans out. They've obviously realised this to a degree. There was an article that went in Management in Practice about a week ago about it, saying that it is now being delayed for GP managers. So thank goodness that we're going to have a little bit of time before they've sorted it out, before we know exactly what we need to do. The next section is powering transformation to innovation to drive reform. So they are talking about 5 big bets for improvement. Again, you're going to hear the same stuff that was in the rest of it, and they seem to have sucked it all into this section. So there is data to deliver impact of a high quality, interoperable health data. So everyone working together with AI, very strongly with AI, working on interpreting that genomic data. So that's back in this section, to deliver personalised prevention and care for our patients, and genomic and predictive and analytics to preempt personalised care. So we need to be aware of this is coming, and have a look at those links that were on there for earlier. They haven't said how this is going to work before anyone asked me, but wearables. So any of you that have got these kind of watches that tell you how many steps you've done, how well you've slept, and you're supposed to add in information on what you're drinking and things, wearables are going to make insights for patients. What they haven't said is what we're going to do with this. I know in certain areas I've worked in, half the patients will own some form of watch that's telling them everything because they've worked, it's an area of more cash. When I've worked in the deprived areas, it's going to be a lot more challenging. They haven't said if we are going to have wearables that we are going to pass to patients and then somehow get back. I don't know if any of you were giving out blood pressure monitors at one point when they did some great thing and then they all disappeared. So they haven't said how we're going to get people doing these wearables, but this is how we're going to be monitoring people's pulses, etc. There will be robotics to support precision. So that's going to be within surgery and things like that, rehabilitation, prosthetic limbs, using robotics to do work in those areas. So that does sound promising. And then there is a whole list of dates. I'm not going to read everything out to you, but you will have the slides that will give you when things are going to happen. So little snippets like by 2028, all your staff will be trained in AI, whether they want to or not. By 2035, at least half of NHS diagnostics will be informed by genomic data. So this is going to become really big. By 2028, wearables will include monitoring for CVD as standard. So again, that's those pulse checks. We're going to have to be aware, but we haven't got any finer detail, just the bigger picture at the moment. There will be an innovator passport when an innovation has been assessed by an NHS organisation, further NHS organisations cannot insist on repeated assessments, which holds back innovation. So it's just cutting out some of that bureaucracy. There will be a single national formulary to stop postcode lottery on medication. So I think that's good. It's not a case of if you have to move somewhere else to get your child's medication they need or your medication, the country will be treated the same. Clinical trials, currently 250 days, that's going to be dropped to 150 days to start research and moving things forward a little bit. And being a part of research is going to be added into the NHS app so people can volunteer through their app. So there's going to be clearer priorities set by the NHS. I'm working through clinical trials and making things easier to get people involved with research. So there's a few little bits on here that you might want to just have a look at and see when these slides come out to you. I'm very cautious that we don't have long left. So I'm going to whiz through this and talk about the finances and the money, which is something that obviously is quite interesting for anyone that's in a management role. So for the next 3 years, there'll be a target to deliver a 2% year-on-year productivity gain within the NHS to get us back to pre-pandemic levels of activity. And then we are going to have to look at ways of cutting costs. So there is going to be the cutting of excessive bureaucracy through the red tape challenge, ensuring best value medicines are constantly adopted everywhere, so modernising our supply chains. And the Institute of Health and Social Care Excellence will have new powers to withdraw treatments that are no longer cost effective. So things are going to change. Excuse me. Technologies like ambient voice technology to free up staff time so they are free to care will be coming in, so world-class care can be delivered. There'll be expert advice on rising costs of clinical negligence claims. They haven't given us any further detail, particularly on that, but things are going to change. By 26-27, all NHS organisations are going to have to deliver operational plans that are compliant with NHS planning and guidance. There will be no exceptions. That means GP surgeries will have to deliver operational plans. By 2029 to 2030, most providers will be expected to generate a surplus. I don't know how that works with partnership because the surplus is profit. So they haven't made this clear how this can work in GPs. It certainly is expected to work in hospitals, transforming the NHS into a driver of growth rather than a burden on public finance. So basically any surplus should be reinvested on future capital projects in agreement with their agreed annual plans. It isn't clear. There may be that a certain amount of your profit will have to be regenerated back into your buildings, your estates, looking after your staff, but that hasn't been made clear. So don't take that as read. There is just a suggestion that GPs are going to be involved in this, but no real suggestion on how that is going to work going forward with partners. It is definitely set more for something where you would have a lot of salaried GPs working somewhere if you're looking at the GP side of things. All organisations, this would include GP surgeries, to produce 5-year plans to show how financial sustainability can work for their organisations. And in the future, all organisations will be expected to spend at least 3% of their profits on a one-time transformation project. So this is something that Some of you will have great partners that work very much onto improving things all the time and working and getting stuff. So it is absolutely right. We all know there are practices out there that don't have that. And those practices, it is going to be harder for the doctors to keep all of the profits and not replenish things back into the surgeries, we are told. But again, no detail. ICB will hold the right to withhold money if poor care is received. That is to hospitals, that is to GPs, and that's going back to that patient power that we mentioned before. So when they said they are going to ask patients, did you receive good care? And if that patient says no and can give legitimate reasons, the ICB can hold back some of the money that care should have gone. They can't keep that money. There is going to be a special budget where that money goes into, so the money won't just go to some member of the ICB. It will actually be allocated to a special area for to go back into the NHS, but not necessarily to the provider who has perhaps failed in care. And then there will be year of care payments to be established. So that's going to be known as the YCP, with an allocated budget for all care across hospitals and primary care. And these budgets will assist shifting hospital finance into community finance. So putting that money across to us if we pick up the work. 26-27 will see the end of deficit funding. So at the moment, if a hospital goes into deficit, the ICB pick up and pay that money. That is something that has been causing more and more problems in the NHS. You will be aware that doesn't happen with us in GP surgery. We have to manage our budgets, which all of you are probably doing as part of your management role. But that doesn't have to happen in hospital. They are shifting this, so it does have to happen. I know 1 year or a lot of the underspend on ours in Lancashire and Cumbria went to prop up the hospitals instead of it going back into general practice, because they said, you guys have managed really well, but the poor hospitals haven't, so we'll give them all the money. That's going to stop. Everyone's going to have to manage their own budgets. And when we look at the banding that is being held in these top hospital jobs, they should be managing their own budgets. That's my opinion, and not that of GP excellence. So our final one we look at is productivity and a new financial foundation. So that is looking at estates and what we are going to have to do with estates and improving things, and there will be a 10-year infrastructure strategy that is going to be published and going through exactly how things are going to work with that. So there will be devolving more control over capital budgets to the front line, with fewer restrictions on what providers can spend their capital on and greater flexibility to spend funding between financial years. The government will be expecting to reduce sort of 2 to 3 months on a typical time a scheme is spent going through the approval system to try and make things happen a little bit quicker. And there will be the new NHS Foundation Trust will be able to progress large self-finance schemes and work them through an awful lot quicker. And the government will do more to align financial incentives to increase estate utilisation and disposal of underused and surplus land. I'm not sure how many of you know much about the estates. There are an awful lot of hospital buildings at the moment that are filled with old chairs that will never be used again, old desks, old equipment, because someone thought, I know, we'll store that because we might use it again. They're never going to use it again. And then we are maintaining buildings at the moment on prime real estate land in order to store stuff that will never be used again. A lot of that is going to change, and that land is going to be used to put up these new mega health centres that are going to be going in, because we have the land, we have abandoned hospital buildings on that land, and nothing is happening with it. So they are going to look at actually regenerating what we already have out there. So this is basically your plan. So there are, as I said, there are 9 parts to there. We have had a brief run through of the way the plan is written at the moment, but things are changing quite dramatically. The plan is very much an overview with not huge amounts of details, but as I have said, I will be sending you out my version that's sort of like an action plan that will at least give you sort of the prime details that are in there. So everything that in my plan has come from their 10-year plan, with dates attached to it that you can just use to run through with your teams if it helps you. And of course, I'm always happy for you to use any slides that come out to you if it is helpful when you're trying to explain things to your GP partners or the rest of your team. But it's just a little bit of an overview of what the plan looks like and how that's going to look for us. There are some very good parts to it. Obviously, we've got, it's great to know that working forward, the GP practice manager's role is actually going to be considered an important role with accreditation attached to it, even if that's going to be towards the end of the plan and not right now when we'd like it. I think it's really good, and those of you that haven't looked at IGPM, it's probably worth having a little look at their accreditation, even if you don't feel ready to do it, just to see what's out there at the moment, but we don't know that's going to do. Will the information, sorry, this has just gone in the chat, will the information you intend to share be sent direct to your emails or shared in Teams? I believe that they send it out. I don't get involved with what happens after this. I believe it will go out as it normally does after training, which I think goes to your emails. I think somebody could correct me if that's wrong, but if you've normally attended something from there, yeah, I can see a thumbs up. So some lovely person working in the admin part of things. So that will probably be either Rose or one of her. She's got an apprentice at the moment, I believe. So that could be somebody from there that will help get the stuff sent out to you, which will just be this one plan, one action plan, and the copy of the slides that should hopefully help you through that. I'm hoping today's been useful to give you that bit of an overview. It is a great big document. Yes, it would be great to read it, but I know that in real life you are all very, very busy. And if that has helped you just break it down a little bit, hopefully that will just save you a few minutes to them rather reading a lot of the stuff again and again, as we often do. So thank you very much for your time today. Have a wonderful rest of your day. Looks like the sun might try and break through. And thank you so much for your time. Oh, I can see, did I see a hand go up? A hand went up and went down again. So if you have a question and I've missed it, if you want to take yourself off mute and just speak to me, I'm very happy to listen and see if I can help. But it looks like a lot of you have at least found something useful. So that's great. Oh, hello, Vera. I didn't realise you were on. Great to see you on there. I don't know how I can teach you. You've taught me so much over the years. I'm just going to stop the recording now.